Hey OncoPTs, and welcome back to this episode of the OncoPT podcast. Most cancer rehab clinicians are aware of how cancer rehab helps patients, right? Hopefully, if you are listening to this, you at least have an inkling of how we're able to help our patients. But I think in general, rehab and even cancer rehab to an extent is less familiar, is less aware of how we can work with patients who have advanced cancer, specifically those who are in the end stages of their life, whatever that looks like for them. But what's interesting is that these patients with advanced cancer and even with terminal diagnoses perhaps need rehab more than our other patients, which is a little bit of a mind shift if you haven't thought about that before. Now, November is Hospice and Palliative Care Month, so now is the perfect time to talk about this, specifically because I hold this patient population very near and dear to my heart. I'm going to be real with you. I did not treat this patient population when I first started practicing. In my clinical rotation, and even for the very first part of when I was practicing as a big girl PT, right, with a PT license all on my own, I really didn't see this patient population. But once I started seeing patients with advanced cancer, it's like the floodgates opened. And it was never like I didn't see them. It's just more of I wasn't actually aware that I was seeing these patients. So to recap a little bit of what we've discussed in other episodes of the OncoPT podcast, hospice and palliative care are not the same thing. They're lumped together, including in our Hospice and Palliative Care Awareness Month here in November, but I want to make just a couple distinctions before we dive into like a little more of the meat and potatoes of this episode. So palliative care encompasses all parts of cancer rehab, from diagnosis all the way through treatment, even after treatment. And for some patients, that means into long-term survivorship. They are, never going to deal with cancer again. Or for our patients who maybe don't get to that end point of treatment, right? Maybe they are going to continue on treatment for the rest of their life. Maybe their cancer comes back. They have a recurrence and they have to go through cancer treatment again. Whatever that path, whatever that experience looks like for our patients, palliative care is truly at every step of the way. And here's why. Palliative care focuses on symptom management and quality of life improvement for patients with a chronic illness. And cancer fits into that. Cancer is a chronic illness, whether or not we like to think about it or not. So palliative care is like this umbrella that goes from start to, quote, finish when it comes to cancer, from diagnosis to and through treatment, all the way until treatment ends, and then end of life, whatever that looks like for that person. Meanwhile, hospice is under that palliative care umbrella, but is not the same thing. What I would equate hospice to more so than hospice equals palliative care, hospice is end of life care. And I'm going to try and use that terminology for the remainder of our episode today because I want to make that very, very clear. We're not talking about the same thing when it comes to hospice and palliative care. So hospice has similar goals as palliative care. Specifically, we are managing symptoms. We are trying to promote quality of life as much as possible for that patient and their family. But what we're really focusing on care here is for that individual who does ultimately have a life-limiting illness. Now, there's different textbook definitions of like what technically hospice is. So for example, I had an uncle kid you not, he was my great uncle. His name was Uncle Tom. And Uncle Tom was on hospice for the last 2 years of his life because genuinely, medically, and on paper, he looked like he was going to die in the next 6 months. And that was something that was very much agreed upon by medical professionals, but he just kept hanging on. And so for him, he was on hospice for 2 years. Now, he didn't have cancer, let's be clear. But just because someone's on hospice doesn't mean they're going to keel over tomorrow, right? Whatever that looks like for them, they have a life-limiting illness, which is what ultimately is going to qualify a person for hospice or end-of-life care, right? Now, per the American Cancer Society, I really love this definition, which is why I've included it here. The hospice philosophy accepts death as the final stage of life. It affirms life, but does not try to hasten or postpone death. Hospice care treats the person and the symptoms of the disease rather than treating the disease itself. And this is where we can see some key differences here. Anyways, back to the definition. A team of professionals work together to manage symptoms so that a person's last days may be spent with dignity and quality, surrounded by their loved ones. Hospice care is also family-centered. It includes the patient and the family in making decisions. And I think this hospice definition is it's so all-encompassing, because at the core of it, of course, we have the family. At the core of it, we have the patient, but then we also include the family in this decision-making unit, right? It's not just the patient making these decisions, but also incorporating like spouses or partners or children or other loved ones who are important to this patient as we're working together as a team, which is another aspect of this definition I love so much, to ultimately create the most dignified experience for this person who is going through this life-threatening illness. So even if we zoom out more, there's a lot of crossover between the goals of hospice and palliative care. Palliative care encompasses hospice, but hospice is a part of palliative care. I hope that has been clear right now. If you want more information on this, I would really, really encourage you to listen to episode 266 with Dr. Lori Boatwright, where in this episode we talked all about the role of palliative care within prehab, which is another really exciting mind shift that I've kind of been experiencing and exploring more within my own cancer rehab professional journey. So anyways, would really encourage that. I've also included that link in today's show notes. The whole goal at the heart of this, the whole goal of hospice and palliative care is to improve a patient's quality of life by relieving symptoms and by addressing their impairments, while still ensuring that the patient and the family unit are supported. And as it stands right now, rehab is not well integrated into this end-of-life care, particularly unfortunately, I'm not trying to be like a broken record here. Rehab isn't well integrated into cancer care, period, but it is especially not well integrated into advanced cancer care situations. We need rehab to be accessible and consistently included for our patients. And like I said, we know that's not the case in cancer rehab, period, but we know that's especially not the case for our patients who have advanced cancers. And there's some really significant barriers that are otherwise preventing this widespread inclusion and integration of rehab into advanced cancer care. This can include inconsistent referral patterns, right? Some patients are referred, some patients aren't, and there's not really rhyme or reason to why this happens. There is a lack of including PT in these, quote, core services. So when we think of hospice, when we think of end-of-life care, rehab doesn't always come to mind, and it's a lot of times due to a lack of understanding of what we can actually do. And this is not to put blame on the oncology team, right? I know, because I've experienced it myself, but also diving into the literature, that even rehab is not very aware of what we do in end-of-life advanced cancer situations here. So we're even to blame here. Like, we don't always understand what we do or how we could serve these patients in this domain, and that's definitely a barrier to all of this. It's important to communicate the goals of the plan of care, and we know that sometimes communication is very lacking when it comes to what the patient wants, what the family wants, what the medical team is working towards, what the rehab team is working towards. We may be working towards very, very different things, when in fact we need to all be working towards the same thing. And at the heart of that, what does that patient want to be working towards, and how can we all come together to make that happen? Ultimately, this and more barriers really contribute to this lack of access for physical therapy services. And there's a great article, I have linked to it in my references for this episode, so I would definitely encourage you to check it out. It's an article by Wilson et al. From 2017. And this quote is just like, mic drop. Lack of access to physical therapist services may mean more pain, more disability, longer institutionalization, more family burden and stress, and poorer quality remaining of life. So this is not just a situation where it's like, Mr. Smith didn't get out of bed today, we'll get him next time. This has significant ramifications on the quality of life for this person in their final days. Again, however many final days we're working with here. This is a big deal. And we know that this not only, of course, affects the patient, but also the surrounding community, right? Their family, their loved ones, their friends. And that is not okay, right? We know that we have so much more to offer this patient population. Even if you don't know that yet, I hope that you'll be convinced by the end of this episode. But this is such a key point of like, it's not just they didn't get out of bed. This is potentially causing more harm for that patient. And I don't know about you, but I got into healthcare to help people and definitely not to harm people, right? There was a concept that we talked about, gosh, this was like several episodes ago. I don't even know which one now. But we talked about avoiding harm. I think it was with Dr. Maltzer, actually. Oh my God, I just had that thought. I think it was with Dr. Maltzer that we had this conversation of avoiding harm is not the same as helping patients. Oh. And I think that fits really well here in our conversation about end-of-life care for patients with advanced cancer. Just because we're seeking to avoid harming them doesn't mean that we're actually helping them. And in fact, instead of seeking to avoid harm, we should be seeking to help them. And those are very, very different concepts here. So how do we actually incorporate end-of-life care into our everyday practice? We have to start first with a true collaborative, multidisciplinary approach. As we know, you know this, I know you know this. Patients with advanced cancer commonly experience a variety and a multitude of side effects and impairments. These may be caused from the cancer itself. It could be from their cancer treatments. And let's not forget here, patients who are experiencing advanced cancer likely have already gone through multiple rounds of cancer treatment, maybe even many months to many years of cancer treatment. So we're not even just considering the most recent cancer treatment they've had. We need to go all the way back to what they've been experiencing in the first place, right? What are some of those side effects that they developed during treatment? What are some of those late side effects they developed after treatment was done, etc., etc. So again, these side effects and impairments these patients with advanced cancer can face from the cancer itself, from the cancer treatments, past and present, as well as so many other things. My gosh. Decreased mobility, maybe sedentary lifestyle. We know that sedentary lifestyle, unfortunately, is a very common byproduct of cancer, particularly in our patients with advanced cancer. That can be a big issue. So there's a lot of time and a lot of exposure to a lot of different factors that kind of come with this advanced cancer territory that basically are prime breeding ground for patients to experience things like pain, weakness, fatigue, deconditioned status, dyspnea, anxiety, depression, other mental health issues, right? This is ripe for opportunity for these patients to experience a plethora of issues. And in kind of on top of this, we're just layering on more and more problems because this is real life when it comes to advanced cancer, especially end of life. Beyond this laundry list of side effects and impairments, we already know that's going on, right? We know this is happening. We know this is a problem for our patients. We also know that these can contribute to decreased overall function. And decreased physical function is totally, very significantly associated with decreased quality of life for these patients. Now remember, go back to the beginning of this episode. We were talking about what is the goal of hospice? What is the goal of palliative care? What should be the goal of rehab here? It is improving and maintaining quality of life for our patients. These factors that we're talking about actively harm or decrease a person's quality of life. We have an ethical, moral obligation, responsibility to help with this. So again, if I haven't convinced you already that we need to be involved in hospice end-of-life situations, my friend, open your ears, clean your ears out. The evidence is overwhelming on how much we can really help with this patient population. Now, best way to do so is, of course, through a collaborative, multidisciplinary team approach. Easier said than done, am I right? But it is doable. And so here's where I think we can really harness some of our skills as the rehab clinician, as the onco PT, to really facilitate this. Now, even though you may not be involved right now in tumor boards or grand rounds or, multidisciplinary team meetings, even if you're not involved in those right now, hear me out. You can still get started. Here's how I actually got started in my own practice a few years ago before I was invited to tumor boards and I think I went to case management meetings at some point. Regardless, before I was invited to those, before I started going to those, here's what I was starting to do to facilitate that cooperation, that collaboration between different disciplines. So we're going to go over a couple patient cases here in the future, like later in this episode. But for now, I was really, really privileged to where I was working inside of a cancer center, to where I was very physically nearby some different services. So on that staff, there was a registered dietitian, there were multiple counselors, psychologists, there were a few social workers, there was a massage therapist, there was an acupuncturist. I know I'm leaving people out, but I can't remember who they are now. So anyways, even though I was not employed by this cancer center, I knew of people who were affiliated with the cancer center, and I knew who was available for those patients to get services. Now, that actual connection of getting the patient to those services didn't always happen, because of course patients have a lot of appointments, etc. And so one of the things that I really have found I've carved out a niche for myself, and I would encourage you to do the same, is to serve as a connector. In Onco PT, I don't know of a more powerful way that we can serve patients, of course, like the one-to-one really working with patients. But I think that connector role is such an undervalued, underappreciated, just powerful way of ensuring that, A, we're working together as a team, even if it's not an official team yet. We're working together as a team to address the impairments, side effects that this patient is experiencing, right? So when my patient is coming into me and they are, we have our session, we're talking about different stuff, and they're telling me what they're experiencing, because I do get to spend a lot of time with them, and I bet you get to spend some time with them too. Probably even more than their oncologist, because let's face it, logistics. We get to talk about stuff, and I get to hear about stuff. And because I see them week after week, maybe day after day, I can see changes happening. And they tell me about changes that are happening. And they're telling me what they're experiencing. I bet they're doing the same for you too. And they're telling you what's bothering them. Now, I know my scope of practice, right? This is my box. This is where I stay in my box. And I know when stuff is outside of my scope of practice. AKA like mental health counseling, etc. I'm not qualified to do that. I'll tell my patients, I may be your physical therapist, but I am not your mental therapist. And I would be happy to help you get connected with someone who's more qualified than I am. So again, as you're spending this time with your patients, you can start to identify and pick up on issues that are bothering your patient. And who better than someone who is spending all that time with your patient to then make that connection, make that introduction, right, of the patient to that service provider, whoever that is. Or for you to maybe even reach out to the oncology team, right, the oncologist, the NP, the PA, whoever we're talking about here, to say, hey, your patient, so-and-so, or our patient, that's always a good way, like we share a patient. Our patient, Mrs. Smith, is experiencing blah, 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 reported that she's experiencing blah, blah, blah in our recent session. I think she would benefit from a referral to blah, blah, blah. Can we make that happen kind of deal? And so again, getting to serve as a connector, when you're spending so much time with your patients, you get to really know them, you get to talk about this stuff and hear and observe some of these things that they're experiencing. I don't know of a better team member to do that. And again, I think this is so powerful because even if you're not In a situation where you are at grand rounds, or you're invited to tumor boards, or you're going to case management meetings, or whatever that is, where if you don't feel like you're yet a formal part of the cancer team, I think this is a great way to get your foot in the door. Because if that patient's team is seeing that you consistently are looking out for that patient, that you have their best interests in mind, that you are identifying pertinent issues and helping patients get connected to those services, I think that's a great way to get your foot in the door, and we definitely need more of that in cancer rehab. So, let's go ahead and give you some more tangible strategies, right? How do we approach, so you've got a patient in the door, how do you approach end-of-life care actually in your practice, right? Let's not talk around it, let's talk actually about and how to do it. First and foremost, I need you to listen in. If you've tuned me out, if you've wandered off mentally, come back to me, friend, because this is really, really important. If you are going to work with patients who have advanced cancer, I need you to not only know and understand, but to wholeheartedly believe that OncoPT, that cancer rehab benefits patients with advanced cancer. I know. You're probably thinking, Elise, I already know this. We've been talking about this all episode. It is one thing to say something. It is another thing to actually believe that something. It is very possible to know something logically, like in our frontal cortex here, but not actually believe it, not actually feel it. And in order to genuinely, truthfully, wholeheartedly help this patient population, you need to believe that. You need to believe in your mind and in your soul that you are helping these patients, which I know that's kind of a weird mental block, but it's actually more common than I think we realize in cancer rehab. So again, I know you know that cancer rehab benefits your patients, but I need you to believe that cancer rehab benefits even our patients with advanced cancer. Just to give you a little snippet, right? A little sprinkling of just what these patients experience and how we can benefit them. So patients with advanced cancer often experience disability due to their cancer treatments, the cancer itself. We kind of talked about this earlier. Bed rest, that can happen as a part of all of this. Deconditioning, neurological complications, musculoskeletal complications, and so much more. And already, you know that rehab helps with all of these things. Even for our patients who have complicated oncologic histories, who have medical histories with things you can't even pronounce, aka the first time I ever heard pelvic exenteration. I actually read it and was like, oh my God, what does that even mean? You can make it through, friend, I pinky promise. Even with patients who have multiple lines, who have terminal diagnoses, who are in hospice, they can benefit from cancer rehab. One of the most, I think, powerful and most impactful ways that we can do so is by influencing quality of life, right? We already talked about quality of life, major concerns for our patients. It's actually one of the most distressing experiences that patients with advanced cancer report. Like in the literature, decreased quality of life is one of the biggest red flags. Help, hello, we are having a major problem with this, that it comes to in advanced cancer. So improving your patients' function and independence and mobility are not only helping with all of those things, but they are directly influencing their sense of independence, their quality of life, but also giving them back some semblance of control in a situation where so much has been taken from them by cancer. That's big. That is really, really powerful. And I don't think sometimes that you give yourself enough credit for how much influence you have here to totally transform a person's existence, even in the face of advanced cancer, even in the face of a terminal diagnosis. And I believe that with every fiber of my being. And here's a little extra good news. Best of all, I just love that so much. Patients who have higher levels of perceived support may actually be better able to cope with their cancer diagnosis. And that is huge. especially in our patients with advanced cancer. You may be helping someone to better cope with the worst news of their life. Like, there is nothing good about a situation like this, but you may be able to help that person deal with it just 5% better, right? And that is huge to both that person and that family and just the memory of that person overall, which I think is a really, really good place to be. Remember, your patients with advanced cancer should, in all caps, have access to rehab and be encouraged to participate in order to maintain and then improve, ideally, their independence as much as possible. Now, when you're first working with patients who have advanced cancer, if you're new to this, you may be thinking, how in the world do I even start with all of this? Here's what I do for all of my evaluations. This is a framework that I have adopted from Aaron LeBauer that I found to be really, really good in the oncology space. And I'm going to encourage you to take it and adopt it in your own practice too. So I start with basically 3 prompts when I'm working with a new patient or I'm seeing a patient for the first time. I like to assess where we're at when we start. And this may be, this may look like me asking them a question of, what brings you in today? Or, what are you having trouble with? Or, oh, I see from the note that Dr. So-and-so mentioned that you're experiencing, this, and this. Can you tell me more about that? Anything to get the conversation started on what are some of the side effects, impairments, restrictions, etc. that they're experiencing. But then you need to follow up. You can't just be like, oh, okay, check, you have fatigue and balance problems and falls and whatever. It can't just be a checkbox. You have to follow up with those. So here's your second prompt. How is blah, blah, right? Whatever you established in the first prompt. How is blah, blah affecting your life? Or as a result of blah, blah, impairment side effect, I am having difficulty with this. What in their life, specifically, when we think about ICF framework, I want you to think about like activities, participation. What are they having difficulty with as a result of what you gathered and established in the first prompt? And then you got to follow it up with your third prompt here. And that is some variance of, if I could snap my fingers and blah, blah, right? Impairment side effect would be resolved or decreased, right? Diminished. Maybe I don't have it as bad. I would do what? Or my life would change how? We need that very, very clear path of how, if they had less fatigue, if they had less pain, what would they want to do with that? And that not only can help you obviously write your therapy goals, but also establishing goals that you and the patient and the family unit and the other medical team are all working towards together in some capacity. So even if your patient has a laundry list of impairments, which is pretty typical of what I've seen in this patient population, has a really complicated medical history, and is even nearing the end of their life, you can still help them by starting with these 3 basic prompts. Now, I'm not just going to leave you with some hypotheticals. I've got 3 patient examples that I want to dive into that are actually real people. Of course, I've modified their names. I take patient privacy very seriously. These are 3 real patients that I've treated in the past who were in this very much end-of-life situation here. So first and foremost is Peter. Now, Peter was one of my patients. He was in his mid-70s, and he had metastatic prostate cancer. So long story short, he was diagnosed with early-stage prostate cancer about 10 years ago, and then opted not to pursue treatment, which is totally his right to do so. And then in that 5 years, unfortunately, his prostate cancer then grew and metastasized. And so we're now dealing with metastatic prostate cancer by the time that I had seen him. He had multiple bony metastases, including in his humerus, his lumbar spine, and his pelvis. Those are the ones I remember. And he was very deconditioned when he came in. He was very unsteady, especially when we were doing different transitional movements. And he was pretty weak. And this all really stemmed from the multiple rounds of treatment he had had over the years, Lots of chemo, lots of immunotherapy. I know he had some other treatments, but I can't remember what those were. But this was kind of the foundation. This was like the baseline of what we were working with here. Now, the weakness, the fatigue, the unsteadiness were particularly problematic because he was having difficulty getting up and down off the floor. Now, my first thought was like, why is Peter, in his mid-70s, getting up and down from the floor? Well, eventually it came out Peter was actually couch surfing between his adult children's homes because he wasn't able to live on his own. And that meant, unfortunately, he did not have a bed to call his own. And so he was either sleeping on a couch, he was sleeping on an air mattress, or sometimes he was in a sleeping bag on the floor. And that had tremendous implications on truly how much benefit we were able to get out of rehab because he wasn't sleeping worth a damn in his everyday life. Like, no amount of rehab we were doing was going to outdo the fact that he wasn't sleeping well day after day after day. And unfortunately, because of circumstances, he was frequently being passed from one child's house to the next. And that was the arrangement that they could make happen as a family. So, yes, obviously we had some rehab considerations, but we also had some other stuff going on. And again, this is a great example of a real life patient who's got a lot of shit going on, frankly. So what I did is, obviously in rehab, we're working on, strengthening. We're trying to get him to where he's less unsteady. He's more stable when he's moving around in his home and in his environment, right? We even got to where he was doing some agility drills, because one thing that he really enjoyed doing previously is that he used to be a youth basketball referee, and he loved being able to run up and down on the court with the kids and just like be a part of the games and whatever. And so while we didn't actually get him back to the refereeing, we did kind of make him feel like he was doing some refereeing stuff, which is pretty cool. And then I reached out to social work, because if anybody knows how to get stuff, it was those social workers. Like, they were amazing. And so through whatever magic that they do, they were able to get him a mattress, which was a hell of a lot better than sleeping on the floor. So that definitely helped with the sleeping situation. I'm not going to say it fixed it entirely, but it was at least better than a sleeping bag on the floor. So that is one example, like I said, of Peter, who was one of my patients with metastatic prostate cancer. Marla is another one of my patients. So Marla is a patient I treated a few years ago who was diagnosed with metastatic breast cancer. And what was particularly interesting is that she had malignant lymphedema. And I think that was the second one I had ever seen, because I really hadn't seen this previously, which was kind of exciting, but also like, malignant lymphedema, this sucks. So anyways, Marla, metastatic breast cancer, malignant lymphedema in her left chest, trunk, and then her left arm especially was really bad. And on top of this, unfortunately, Marla also had fungating wounds. If you're not familiar with what this is, fungating wounds, it was really challenging. A fungating tumor is where a tumor that was growing underneath the skin has now broken through the skin and is causing a wound on the surface. And unfortunately, Marla actually had several of these fungating wounds on her trunk, and then I think one or two on her upper arm. So anyways, she comes in for the initial eval, and my eyes were about as big as saucers when she came in for the eval, and I was like, oh my gosh, I'm in over my head. Now, I did know how to treat lymphedema, and I was pretty confident in that, but there was a whole lot of other stuff I was really, really worried about. So I reached out to some colleagues, I got some help, I got some guidance, and ultimately got clearance from the oncologist to pursue complete decongestive therapy. Now, Marla's lymphedema was impacting her ability to function in basically all realms of her existence. Brushing her teeth, getting dressed, preparing meals, pretty much anything. And she relied heavily on her husband to help her do all of those things. And she didn't want to do that anymore, especially because her husband, he had some kind of back injury. So they both had some health problems going on, and she didn't want to have to rely on her husband as much to do all the things. So the oncologist gave us the all clear to pursue complete decongestive therapy because this was the first time I think I had worked with a patient who had metastatic cancer, malignant lymphedema, and like our focus for plan of care was the lymphedema. I've worked with patients previously, but like we really weren't working on the lymphedema because there were other more pressing issues. So Marla was kind of my first in all of this. And so we really wanted to manage the swelling, the heaviness, and the discomfort associated with her very stage 2 upper extremity lymphedema. It was very, very significant. It was very, very heavy. And after a few weeks of compression bandaging and manual lymphatic drainage, we actually significantly reduced her swelling to the point we could then transition out of bandages and into a garment. And that was one of the coolest, like most visibly obvious ways that I've ever reduced an arm in like such a fast, such a drastic kind of way. It was really cool to see. And even in the face of those fungating wounds, so to be clear, she did have some dressings I think that the wound care team was putting on, and we were cleared to apply the bandages over those dressings, just so you kind of have a little background information. Now, it's very common for therapists, especially newer therapists, to be weary or cautious about implementing complete decongestive therapy for a person with metastatic disease. However, these patients can still benefit from complete decongestive therapy. They may just need a little extra attention, caution, or observation from the medical team, right? And like we're a part of this. Of course, like the oncologist or whoever is overseeing care is absolutely a part of this. Like we were all working very closely for Marla's plan of care, and we saw really, really good results. Complete decongestive therapy, especially manual lymphatic drainage, is very helpful for managing lymphedema in patients with metastatic disease. Yeah, it's good for them too. And in fact, MLD can actually significantly lower pain intensity and improve breathing capacity through its effects on like decreasing the pressure on the diaphragm as the diaphragm is trying to keep up with breathing, etc. So there's a great article by Clemens from 2010 that talks specifically about the inclusion of MLD into situations where a patient has metastatic disease. And I really love this quote here. Furthermore, MLD should not be withheld from patients with metastases. Withholding that from them is absolutely not appropriate in a lot of situations. Now, I'm sure there are some situations, right? That's totally valid. But just because a person has metastatic disease doesn't mean that you still can't do a lot of these amazing interventions and treatment protocols to help this person. Now, the last patient that I'll leave you with today is Miguel. Now, Miguel is one of my very, very dear patients. You know, you have these patients that just kind of stick with you for like ever. Miguel is one of those patients for me. So a couple years ago, he was diagnosed with metastatic pancreatic cancer. So he was diagnosed in June, and he was given, about 8 months to live, I think is what ended up being. So this is actually one of the few patients I've ever had who had a very clear life expectancy. Like there was a timeline we knew we were running up against. And instead of that being like, oh my God, I don't know what we're going to do, that in a way actually helped Miguel and I set really, really clear goals on what we wanted to accomplish because time was so finite. So Miguel had 2 goals. He wanted to dance at his son's wedding later in the year, and he wanted to take his wife on a bucket list trip to the Grand Canyon. And so I saw him over the summer and into the fall as he began chemotherapy and underwent chemotherapy to try and improve his chances of living longer. Some weeks were a bit better, some weeks were pretty rough, but overall, he was able to build and maintain his strength. He was able to manage his fatigue, and he was able to continue to get down on the ground to play with his baby granddaughter, which was something he really wanted to do during our time together. Now, again, fluctuating function, but overall, that's what we were working towards and we accomplished. And in November of that same year, we discontinued our plan of care because he was going out of town. And before leaving, he told me that he danced his pants off at his son's wedding and they were leaving town to go on that trip to the Grand Canyon with his wife. I thought I got all my crying out as I was writing these notes, and then it just hit me in another wave. We made it. Miguel was able to dance at his son's wedding, and he made it to the Grand Canyon with his wife, and he died a few weeks after he and his wife returned from the Grand Canyon. And that was one of the coolest experiences I've ever been a part of. Like, I didn't get to hear all of that until after he passed. But man, that was one of the top experiences I think I've had in my career so far, of being able to be a part of that. Whew, okay, that's enough of that. We are not going to do any more crying on this episode, because I was hoping to not to do any crying on this episode, but sometimes you got to do what you got to do, right? Now, I hope I've convinced you, if you were on the fence previously, that cancer rehab, that OncoPT absolutely must be a part of end-of-life care. But you may be thinking, is it worth it, right? Is this something that patients actually want to do with their very precious limited time here on this earth? And the answer from the literature and what I've seen clinically is a resounding yes. Patients with terminal diagnoses often rank quality of life as one of the most important concerns. We've already talked about this, right? And when they're not able to get out of bed, when they can't do their daily activities, when they can't go spend time with family, that adversely affects their quality of life. And those are things that we can be working on, and they want to work on too. And what surprised even me in the literature is that they have found that patients actually desire to participate in physical activity, because at this point, they're probably going to feel better than what they do right now. And that is a great opportunity to capitalize on. Now, I'm going to be honest. I mentioned this at the beginning of the episode. I'm going to say it again here. I didn't think that PT was actually, should actually be a part of end-of-life care when I first started practicing. And that mainly came from, I didn't see it. I didn't see that patients were actually being treated for their advanced cancer and also undergoing rehab, and that they wanted to undergo rehab, because I just wasn't seeing this patient population. So this was throughout my clinical rotation, and even the first months of my solo practice, I didn't think this. And it wasn't until I started getting a batch. You know how patients kind of come in waves? Sometimes I find myself, I'm doing a lot of post-op, breast reconstruction. Other times I'm doing a lot of colorectal cancer. It comes in waves. And this is one of those situations. I was seeing a lot of patients with advanced cancer, terminal diagnoses. And it was feeling kind of heavy. I was like, oh gosh, I'm very uncertain about this. I don't know if I'm actually doing good things. Should I even be working with these patients? I just don't know. And so I reached out to my good friend, mentor, colleague, Joy. She's a massage therapist. And she said something that has stuck with me so fiercely. And I'm so grateful for it, because it was such a shift in my perspective. And I'm so, so grateful, and I'm better for it. So she's listening to me as I'm like, I just don't know. And she, of course, was very encouraging. But then she said this: it's an incredible opportunity to work with... Oh my God, I'm crying again. Hot dang it. Sorry, guys. Let's try that again. It's an incredible opportunity to work with somebody who has chosen to spend their precious time with you. And she was totally right. Now, don't get me wrong. There's sadness in cancer rehab at times, as noted by my now 2 cry fests in this episode. But there is also immense joy. There is an immense opportunity and privilege in being able to work with a person whose time on this earth is so limited. And you can show up in what might be the suckiest time ever for this family and for that patient. Passionately serve with compassion and help make things just a little bit better for that patient and their family. Incorporating rehab into end-of-life care is a challenge. I'm not going to lie to you, but it's worth it. And I hope that you're going to implement this too. I would love to hear from you how you're doing this in your own practice. You can message me on Instagram, and I want to know, how are you making this work in your practice? How are you meeting patients where they're at when it comes to end-of-life care to deliver this high-quality cancer rehab? Because I can bet with certainty that I have something to learn from you in this situation, and I'm always looking for ways to get better at especially this patient population. So message me on Instagram, and I would really, really love to hear from you. Until next time, this is Elise with the OncoPT, and remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.